For this lecture, we're going to dive into Parkinson's disease, multiple sclerosis, ALS, Guillain-Barré, and post-polio. So let's start off with Parkinson's disease is a chronic progressive neurologic condition that affects the motor system. Symptoms are caused by a decrease in dopamine, which is one of our neurotransmitters, and that's stored in the substantia nigra of the brain, which is a part of the basal ganglia. And when we have damage to the basal ganglia is seen in Parkinson's disease, there's damage to the dopamine producing areas of the basal ganglia, and that decrease in dopamine causes the symptom presentation of Parkinson's disease. It's the second most common neurodegenerative disorder in the United States, and men are 1.5 times more likely to develop it. We talked about it's caused by a lack of dopamine producing neurons, and that loss of dopamine correlates well with the amount of movement slowness. And so the more dopamine loss that the patient experiences, the slower they tend to move. And we talked, it's a disorder of the substantia nigra. Clinical features include bradykinesia, which is going to be slow movement, rigidity, and we've got two types there. We have lead pipe and we have cogwheel. Cogwheel rigidity is where we're going to have rigidity that releases and then catches again. And we just have this kind of cogwheel motion as we move through assessing that rigidity. Whereas lead pipe, we feel the rigidity through the entire movement, and it feels like you're moving a lead pipe. Tremors are often considered the first sign of Parkinson's disease, and we have resting tremors versus intention tremors. And resting tremors happen at rest versus intention tremors happen when the person intends to do something. And intention tremors are going to be what we see in patients with Parkinson's disease. Pill rolling is another type of tremor that we can see in Parkinson's disease, and that is seen in the fingers where a patient will seem as if they are rolling something between their fingers, and that can happen at rest or with activity. And patients are typically at risk for balance deficits and falls because of the postural instability experienced with Parkinson's disease. Additional clinical features include fatigue. The rigidity that these patients experience can increase the energy expenditure for any of their functional tasks, and so they can be at an increased risk of becoming easily fatigued because of that increased energy expenditure. They get progressively more tired through the day and experience post-exercise fatigue, and so this is important to consider not only in when we schedule our sessions with patients with Parkinson's disease and how we plan our sessions with patients with Parkinson's disease, but also how we educate them in energy conservation and how to manage their functional tasks throughout the day. When we look at gait deficits in this population, festinating gait is the most common gait deviation that we will see, and this is where a patient with Parkinson's disease will demonstrate an anterior weight shift that causes them to take these short shuffling steps that get faster and faster because they're trying to keep their base of support up with the anterior weight shift of their center of gravity, and causes an anterior fall. They also demonstrate a loss of arm swing, and that comes in with the rigidity. These patients will hold their entire trunk very stiff, and so rotation movements become important in the treatment of patients with Parkinson's disease. And they will move slow with a narrow base of support. Like we talked about, they're at risk of falls because of the postural instability, and the bradykinesia means that they are slower to respond to postural changes, and so they're at risk of falls, loss of postural extension, and the inability to respond to expected and unexpected postural disturbances. And the systemic manifestations can include cognitive slowing, and so for this we want to encourage dual task training as we promote function so that we can enhance cognitive function in these patients. Parkinson's disease can be classified by the stages that Hohen and Yahr have put together, and you can look at that table on page 528 of your textbook. I will tell you that clinically, I don't know that anybody really references Hohen and Yahr stages, but it does give you a little conceptualization of the progression of Parkinson's disease. So how is it managed? Medically, Parkinson's has to be managed with medications, and patients are at a loss of dopamine, but dopamine can't be what is given to them medically because dopamine doesn't cross the blood-brain barrier. So it would go through circulation to the brain, but it wouldn't be able to get in to the brain for the basal ganglia to use for proper motor function. And so since patients can't take dopamine, they take what's called levodopa. It is commercially known as Sinemet, but levodopa and Sinemet are the most common medications for patients with Parkinson's disease, and these have to be timed out pretty consistently because the effects of the medication wear off, and that does present in how the patient is able to function. And so discussing medication management with a patient, again, not only in reference to your treatment sessions, but also their activities of daily living, can be an important part of physical therapy intervention. It's important to note that with long-term use of levodopa, it becomes less effective, and so medication management has to be adjusted with the doctor over time. And therapeutically, the long-term use of levodopa can produce dyskinesias. So that can be like our choreoathetosis, those types of things where we have those abnormal movements that the patient doesn't have control over that are not the tremors. Surgically, they can go in and do what's called a deep brain stimulation. And so what they'll do is put a stimulator over the subthalamic nucleus of the brain, and it basically acts to help stimulate production of dopamine, so that way the patient is not at a loss. And I've seen substantial improvements in patients who have had a deep brain stimulator implanted that happened pretty quickly. And sometimes they'll do adjustments based off of how the patient responds, so that way they can kind of fine tune and get the right motor response. And that's something that can happen not only initially, but they may have to go back for revisions, and they just put the device over top of the skull where the stimulator is so that they can make adjustments. They don't have to go back in surgically, but it does show to prove improvement of bradykinesia and rigidity and some improvements in tremor. So how do we manage Parkinson's with physical therapy? Our primary goal is to help maximize function in a disease process that is progressive. And so most patients we are going to see, or with Parkinson's, we're going to see multiple times over the course of their diagnoses, and they will regress if they do not stay on top of the exercises that we give them. And even if they do, they still have the potential to regress because it is a progressive disease. So our primary goal is going to be to maximize their function given their limitations and teach them strategies to move more easily and adapt to the conditions that they have. Secondarily, we want to prevent deconditioning and any musculoskeletal changes that happen from the stiffness, the rigidity, and the slow movements. And so teaching stretching and strengthening is going to be an important part. Gait interventions and fall prevention are going to be a huge component because all of these movement disturbances decrease their ability to respond to disturbances and decrease balance. So we need to look at the causes of our gait deviations and address those through gait training, and also look at any other areas where they're at risk of fall and address those specific deviations. Areas that patients with Parkinson's typically struggle are going to be with the initiation of gait. These are patients who are going to be susceptible to freezing episodes, and things like doorway thresholds, change in walking surfaces can trigger those freezing episodes. And so part of our goal is to place those obstacles in front of them and help them be able to initiate gait and continue with gait and get through those freezing episodes. We need to work on not only straight walking, but turning and gait adaptability over different surfaces. And when appropriate, because they don't need to utilize an assistive device, we want to make sure that we encourage arm swing, because that's going to give the trunk rotation that they need and improve gait efficiency to combat that fatigue. Postural intervention should focus on postural responses and rotation. Remember that they have a slower response to both expected and unexpected disturbances. And so we want to make sure that we're encouraging the ability to react to help, again, focus on decrease fall risk. And relaxation techniques, again, posture is going to be affected by the rigidity and the tone that this patient experiences, and so giving them relaxation techniques to achieve appropriate posture in a neutral spine is important. When we are implementing exercises, we know that we need to use stretching strategies for these patients, but our stretches need to be held for at least 60 seconds because of the increased muscle tone. We want to focus on strengthening the postural extensors so that we can have better responses and combat the flexion-based posture that patients with Parkinson's are susceptible to due to that rigidity. And again, incorporating those rotational movements to enhance trunk movement, because that is something that they lose very quickly. The use of functional movement in PNF patterns can be really important to enhancing that rotational movement. Table 14.3 on page 530 gives you some exercise strategies specific to activities of daily living through the neurologic population. I don't believe it's specific to Parkinson's, but it's a good application to look at here. Another treatment approach that we need to be aware of for patients with Parkinson's disease is going to be the LSVT Big and Loud program. And this was developed by Lee Silverman, that focuses on Big motions, because part of the problem with Parkinson's is that they are stuck on small motions, and so all of the exercises incorporate big motion, moving through full range of motion with multiple body segments, and loud counting, loud interactions, because uh, voice is often affected in Parkinson's with the volume, and so big and loud helps to combat two of the areas that Parkinson's patients suffer deficits in the most. If you are feeling froggy, go ahead and look up a video on big and loud treatment. There's a million out there, just to give you an idea of what that looks like. And then another intervention to be aware of for Parkinson's disease is that whole body vibration has been shown to decrease tremors, and so that is a physical therapy intervention that can often be employed. Moving on to multiple sclerosis. So MS is a chronic debilitating demyelinating disease of the central nervous system affecting young adults ages 20 to 40. So this doesn't mean that patients can only be 20 to 40 years old if diagnosed with MS, but it means that diagnosis typically happens between 20 and 40 years old. And it is it's seen 2 times more frequently in women than it is in men. And so this is important just for understanding the patient population that you're going to be working with in an MS population. What happens with MS is there's a demyelination of the white matter in the brain and the spinal cord. So our brain and our spinal cord make up our central nervous system, and the white matter loses the myelination, and so the signal can't travel through the central nervous system as fast, because remember that myelinated axons are able to transmit the signal faster down the axon because it can jump between the nodes of RAMBA. Without that myelination, there's increased energy expenditure that then causes further axon degeneration, that then causes further deficits because of the missing or demyelination in the first place. Leaves the axon unprotected, further degradation happens with the increased energy expenditure and ATP consumption. Clinically, this means that MS presents with some impairments, and sensory impairments are often the first sign of MS. Patients who are diagnosed with MS will report experiencing changes in sensory perception before they experience changes in motor perception, and that's just because of the difference in the sensory and motor thresholds. Fatigue is a huge clinical presentation of MS, again, because of the increased energy expenditure that's required because of the demyelination of the axons within the central nervous system. These patients require more energy for any signal to be sent to or from the brain, and so that causes an increased level of fatigue. It's the most frequently reported symptom, and it is often out of proportion with the extent of the disease, and so it doesn't really matter what level of the disease they're in, they can experience high levels of fatigue. And it's really important to note that heat worsens fatigue in patients with MS. So whether that's working with them in a pool that is too warm or a gym environment that is too warm, we really need to focus on cool environments for these patients to limit the effects of fatigue. Cognitive impairments can also be seen in patients with MS with difficulties with problem solving, short-term memory, visual spatial perception, and conceptual reasoning. Information processing speed is the most commonly affected, and that's known as bradyphrenia. There's definitely an MS personality that occurs with the changes in cognition, and a lot of times there can be a decreased awareness for safety and self-perceived limitations, and so patient education can become very important in this population because of those cognitive impairments. Autonomic dysfunction can also be seen, where these patients will experience urinary retention, often with a spastic bladder that holds urine in, and so they can require intermittent catheterization to eliminate urine. They can also experience loss of bowel or bladder function if they go the opposite direction. Instead of spastic bladder, they may have a flaccid bladder that promotes urinary incontinence or bowel incontinence, and they can also experience sexual dysfunction. The disease course is unpredictable because the presentation is highly variable. So if we take a look at that highly variable presentation, there's a couple different types of multiple sclerosis. And the most common one that you will see is going to be the relapsing remitting MS, and that's going to be the top right one here, to where we have a baseline level of disability over time. And so our patients start at normal level of function, and they have a relapse of the disease process. And through that disease process, it will have them at a higher level of disability until they're able to recover, and they typically return to baseline in those initial relapses. But further relapses, when that relapse remits, their level of disability increases and they're not able to return to baseline. That can be compared with secondary progressive MS, which is always progressing. There's never any return to baseline, but it does have these relapse spikes and brief remittances. But again, there's no return to baseline there. Our clinically isolated syndrome is a one-time occurrence of a relapse of MS where the level of disability increases tremendously. They're never able to return to baseline, but there is an improvement to near baseline level of function with no recurring relapses. And then primary progressive MS, which is going to be our bottom right here, again, just shows where we have this progressive loss of function, increase in disability, with sometimes having relapses that cause spikes in decreased function, but that's not always present with primary progressive MS. Diagnosis of MS is made with cerebrospinal fluid examination, where they'll go and look for evidence of myelin protein in the cerebrospinal fluid. And then also MRI, they'll go in and look for presentation of the plaque developments in the central nervous system. Medically, it is managed with medications. That's the mainstay of management of MS. And there's synthetic immune system modulators that are used pretty commonly in MS. The ABCs are going to be your three most common. So Avonox, bedazoline, and Capoxone. Your Tysabri and your Naboxatrone are intravenous medications, and so those are less commonly distributed to patients with MS because of not having the same ease of transmission. Overall, our goals in physical therapy are going to be to minimize the progression of the disease process and maintain their optimum level of function and independence. We want to prevent any secondary complications, but basically trying to maintain whatever level of function that the patient has. We're not likely going to increase their level of function unless they're in the midst of a relapse, and so it's about minimizing progression. When the patient experiences weakness, it occurs directly from the lesions or secondarily from inactivity. So we can see atrophy that's related to a decrease in innervation, or we can see atrophy that's related to a decrease in activity levels because of increased difficulty and fatigue with performing activities. We want to include exercise training, aerobic conditioning, fatigue management, and gait training. Energy consumption can be decreased during functional activities by placing emphasis on strengthening proximal muscle groups. So our goal in therapy is going to be emphasizing strengthening of proximal muscle groups at the hips and shoulder to promote stability through the limbs for decreased physical demand when performing functional activities. Use of PNF patterns for functional training to strengthen and help with spasticity. And strength and endurance should be addressed with submaximal aerobic exercise in a cool environment, remember, because of those fatigue effects. Spasticity occurs secondary to upper motor neuron lesions, and the patient and family should be taught self-stretching with particular attention to stretching the cervical region, the hamstrings, and the heel cords, because these are the regions that most commonly develop contractures in patients with MS. The plantar flexors, adductors, and quadriceps are also often involved, and so we want to make sure that patients and family members are proficient in stretching all of these muscle groups. Ataxia can be seen in patients with MS, and utilizing PNF patterns such as alternating isometrics, rhythmic stabilization, and slow reversal holds in an ever-decreasing range can help to improve that coordination of movement. Functional movement transitions can be important for safety if a patient's demonstrating ataxia, and so practicing that functional movement transition, again, will help improve the coordination of movement and decrease fall risk. Balance training, I think, is pretty self-explanatory there. The Frankel exercises can be found in table 14.5 on page 544. I would take a look over those and just see how you would implement them in a patient with MS in preparation for coming to class. And use of weights as appropriate. Remember, trying to consider their fatigue level and stress them appropriately without overstressing them. Additional concerns include that these patients often suffer from emotional lability, meaning that they have limited control over their emotional expression and they can go from laughing to crying very quickly. And this kind of factors in with the cognitive impairments, and so we just need to be mindful of those psychological factors when discussing things with the patient, educating the patient, working with them in general. They also may experience nystagmus or vertigo, which can obviously interfere with their balance responses. Amyotrophic lateral sclerosis, or ALS, is a terminal progressive disease involving both lower motor neurons and upper motor neurons. And this happens because of damage to a couple of different areas, but one of the areas that's affected in ALS is going to be the anterior horn cells of the spinal cord. And this is where our upper motor neurons and our lower motor neurons meet, and that is why we can get a mixed bag presentation of both upper motor neuron and lower motor neuron involvement. It's the most common motor neuron disease in adults, with 2 per every 100,000 adults. There's approximately 30,000 cases in the United States, usually occurring between middle and late sixth decade, and men are slightly more likely to develop ALS than women. There's an unknown etiology, except with an inherited form. There are some types of ALS that have a genetic link, but not all types of ALS have the genetic link, and they don't fully know what causes those ones that do not have the genetic link. The typical prognosis in a patient who's diagnosed with ALS is they're given 2 to 5 years to live. Clinically, these patients are going to present with muscle weakness. The majority present with asymmetric weakness in one arm or leg. And so that's helpful because that gives them a stronger side to work with. But that's important for us to just be mindful of how they're going to need to complete things, especially with a progressive disease. We need to make sure that if they have a weaker side, we are training them to transfer towards their stronger side. We are teaching them how to maintain balance by turning towards their stronger side when they are out in the community and those types of things. There's typically no eye muscle or sensory involvement because of the areas of the nervous system that are involved. There's no cure for ALS. The only management is going to be symptom management. There's no medication to help improve the symptoms. Like Parkinson's and MS, it is a progressive disease that's going to continue to worsen over time, but ALS is much more aggressive than Parkinson's or MS, and there's no medical management to slow the disease process at this point. There's only management to help manage symptoms that develop as a result of the disease process. Physical therapy management is going to include addressing the weakness that has developed, remembering to be mindful of fatigue, but we really want to focus on concentric exercises because eccentric exercises cause increased muscle fatigue and increased muscle soreness and decreased responses compared to concentric exercises in this population. So with patients with ALS, we want to avoid eccentric exercises. We can use moderate resistance in muscles with 3 out of 5 strength or better, but we should not use resistance in muscles with less than 3 out of 5 strength. They have to be able to at least go against gravity before we can add resistance. Otherwise, we just want to work them either in an anti-gravity position to get through full range, trying to promote their ability to achieve a 3 out of 5 before we add resistance. And as they continue to progress, pulmonary care is going to be a huge component of physical therapy management because respiratory muscles tend to be involved with ALS, and that decreases the ability not only to take deep breaths, but also clear lung secretions and all of those things. So pulmonary care becomes an important component as the patient degrades. Moving on to Guillain-Barré syndrome, GBS is the most frequent cause of acute generalized weakness now that polio has been eradicated. And it's referred to as a syndrome instead of a disease because it has this broad presentation of pathology and how it affects the neurons, and it's not always consistent in each neuron path that it affects. And so it's diagnosed, or it's classified as a syndrome and not a disease, but I wasn't there when they named it, so don't ask me any more than that. It occurs in all ages, and the majority that acquire it experience a respiratory or gastrointestinal illness before the onset of weakness and sensory changes. So there are some premeditating factors before any motor weakness is experienced. Typically, some kind of infection can be correlated with GBS. However, the identification of that infection doesn't always happen until after in hindsight, or at least making the connection between having that infection prior to the onset of the GBS. It is an autoimmune reaction, and so that's why having an infection typically is correlated with something that happens prior to the onset of GBS. And when that autoimmune reaction occurs, the Schwann cells are destroyed in the peripheral nervous system. So where MS affected the central nervous system and the myelin of the central nervous system, GBS affects the myelin of the peripheral nervous system. Clinically, these patients present with weakness that progresses distal to proximal. So you will see weakness at the ankles and the wrists before we will see weakness at the hips and the shoulders. It will progress proximally up to the trunk. When it returns, these patients experience returns in muscle strength the reverse direction in which they lost it. So they lose it distal to proximal, they gain it proximal to distal. Distal sensory impairments often present as paresthesias, where they can talk about those abnormal sensations or pins and needle feelings, and they will experience myalgias or muscle pains. Medical management of GBS includes plasmapheresis and in the infusion of immunoglobulins, or IVIG. So both of these treatments tend to happen within the hospital because they are intravenous. And so these patients typically require transition from an acute care setting to either an inpatient rehab setting or a skilled nursing facility, not only for improvement of physical function, but also for medical management. So we have a couple different phases of Guillain-Barré. And during the acute phase, our main goal is to minimize the signs and symptoms. And so we're going to support pulmonary function. We're going to address range of motion, typically by providing passive range of motion, but active assistive and active range of motion as tolerated. We want to educate them on pressure relief and skin checks to prevent any kind of skin breakdown, and also positioning to prevent contracture formation. And we want to limit exercises to movements without pain. So if we are seeing patients experience an increase in pain, this is a population where we're going to say, okay, this is a stop. Not all of our patients do we stop just because something hurts, but this population we will, especially in this phase. During the plateau phase, this is when we're going to work on the acclimation to upright posture. So whether that's use of the hospital bed, use of a tilt and space wheelchair, use of a tilt table, we need to get them able to tolerate an upright position with normal blood pressure to progress to normal function. We're going to continue range of motion, again, working towards active range of motion as appropriate, improving pulmonary function because we don't want to just support it now that we're in a plateau. We want to help encourage better breathing, better airway clearance, all of those things, and continue to promote pressure relief, skin checks, and positionings, again, trying to prevent contracture formation, because the more somebody stays sedentary, the more at risk they are for these things. The recovery phase is going to begin 2 to 4 weeks after the condition has reached a plateau, and this is when we can start to push patients a little bit, but it's very important that we are careful with not over-fatiguing our patients with Guillain-Barré, because over-fatiguing a patient with Guillain-Barré can cause them to have a complete regression of the condition. And so we can exacerbate that autoimmune response if we over-fatigue these patients. We understand that the strength is going to return in the opposite direction in which it was lost. So we're going to have returns from proximal to distal. We want to strengthen and maximize functional ability, still trying to limit movements to exercise without pain. We can push a little bit more in the recovery phase, but that's going to be something we consider a little more heavily than any other population. And again, be careful of fatigue. A couple of guidelines to help you in selecting your treatment interventions and planning your treatment plans for patients with Guillain-Barré are going to include the Bentzman's guidelines, and those are to use short periods of non-fatiguing exercise to match the patient's strength. We want to increase difficulty or the level of exercise only if the patient improves or there are no deteriorations in status after a week. We want to return the patient to bed rest if a decrease in strength or function occurs, and direct strengthening exercises at improving function, not merely improving strength. So we're not going to do a whole lot of straight plane strengthening stuff with these guys. We're going to keep things related to function to minimize the fatigue effects. Moving on to post-polio. So polio is a viral infection that we have a vaccine for now, and so polio has been eradicated in the United States. We don't have patients who experience polio, but because the epidemic ran from 1910 to 1959 before it was eradicated in the United States, we do have a patient population that is alive who did develop polio in sometime in their lifetime, and as a result of having had polio at some point in their lifetime, they can develop post-polio syndrome. They're not really sure why it happens, other than the person had to have had polio in their life, but it does result in a destruction of it happens as a result of the giant motor neurons that formed during the recovery process of the original virus. So when polio hits a person, there's injury to the motor neurons, and when the recovery happens, there's these enlarged motor neurons that rebuild in the recovery process, and those giant motor neurons are what cause the onset of post-polio. Clinically, they present with fatigue, with extreme fatigue being described as hitting a wall. With all of these pathologies that we've talked about today, fatigue is an important component. It can happen at the same time of day and can be accompanied by symptoms of autonomic distress. So these patients with post-polio typically have a routine that you can work around for your treatment, but also educate them for their performance of their functional tasks. They will know when they're going to hit that wall because they've experienced it enough times. And when they hit that wall, it's not just a matter of being tired, but they can experience things like diaphoresis, increased breathing rate, increased heart rate, all of those things that indicate autonomic distress. New weaknesses can occur, so these patients may not have ever gotten back to baseline level of strength following the diagnosis of polio, but with the development of post-polio syndrome, they are acquiring new weaknesses that occur in muscles that were already involved but had not shown clinical weakness as a part of the original polio infection. Overuse has been associated with this, and so again, fatigue becomes an important factor. We need to make sure that we do not cause overuse in these patients when we are working with them in any of their muscle groups. But we also need to educate them on how overuse in their functional day-to-day tasks on these previously unaffected muscle groups may have caused the post-polio, and so why that might mean they need to modify some of their activities, change up the way that they do things, work on energy conservation, those kinds of things. Pain is a common presentation in patients with post-polio. Again, I think that's typically associated with the fatigue and the inability to provide muscular support to the joints that need to be supported. And patients typically respond well to pacing activities to avoid the fatigue that causes the pain. Sensation is not typically affected in post-polio syndrome because it is a result of the giant motor neurons being affected, but they can have sensory symptoms such as cold intolerance. I don't know that I have an explanation as to why that is a symptom, but it is associated with post-polio syndrome, and decreased function associated with the weakness and fatigue. So how do we treat somebody with post-polio syndrome? General guidelines, we want to make sure that we avoid overuse and disuse. So we don't want to overstress one area and avoid using one area. We want to have a balance of our muscle groups, but again, being mindful of that fatigue threshold. Modify the level of activity to decrease pain. Monitor their vitals. Use a Borg rating of 14 or less in this patient population to avoid over-fatigue. There is a non-fatigue protocol. I've got the page number, I think, in one of these next slides coming up. But we want to use a short duration with a sub-maximal workload, trying for an every other day schedule. So again, minimizing fatigue. Recommending aerobic exercise to improve overall functional capacity, and aquatic exercise to decrease stress on the muscles and joints with the performance of exercises. Stretching may not be indicated because of the potential for increasing joint instability. So a lot of times these patients are relying on inherent tension in their muscles for stability because they do not have the strength as a result of the original polio or now the post-polio. And so we have to be very mindful in stretching these patients that we don't take away their stability by stretching them inappropriately. Persons with post-polio syndrome may already have a delicate balance of ligament and muscular tightness that substitutes for weak or absent muscles, and any increase in range of motion must be supported by adequate strength. We can only use gentle stretching for cramping or pain. We don't want to use aggressive stretching. We've got 3 types of pain that we can see in patients with post-polio syndrome, and how we can help them handle that depends on the type of pain. So cramping pain, we're going to use gentle stretching. Musculoskeletal pain is typically going to be caused from inflammations or strains, and so we can educate patients on the use of anti-inflammatories and utilize modalities to address that. And biomechanical is going to be the result of how the joints move and postural alignment, and we want to educate them on posture, use of assistive devices, and appropriate orthoses to promote proper joint alignment to decrease that pain. Lifestyle modifications are going to be important, again, because of the fatigue factor, because we don't want to have overuse of one muscle group with underuse of another muscle group. All of these factors that weigh into their progressive decline. People with PPS must change their lifestyle. We have to reduce physical and emotional stress, promote joint protection, home and work environment modifications, and the use of assistive devices to reduce fatigue and preserve function. And part of that's going to also include energy conservation, which is necessary due to the effects of fatigue and the danger of overuse. Medically, there's no treatment proven effective for the pain management or the fatigue, so really treatment of patients with post-polio syndrome falls to us in therapy, giving them the best education and adaptation and strengthening possible to maintain their maximal functional level. So physical therapy management, like we've talked about, should include exercise, stretching as appropriate and as needed, pain management, lifestyle modification, energy conservation. The goals of PT are to ambulate safely with optimal functional independence, avoiding fatigue and muscular overuse. And that non-fatiguing exercise protocol that we talked about is on table 14.7 on page 553 of your textbook.